Hello, my name is Adam Berman, and I will be presenting our abstract entitled Reduction in 30-Day Emergency Department Readmissions Using a Hospitalist-Led Team. Thank you to Sarah Jacobs for putting these slides together. We have no disclosures to make. As a background, the Long Island Jewish Medical Center Emergency Department is an urban, academic tertiary care ED that serves a diverse patient population, including many patients who have poor access to health care and those who represent vulnerable patient populations. The ED is located on the border of Long Island and Queens and serves New York City and the surrounding areas. Vulnerable patient populations include patients with low health literacy, limited English proficiency, limited access to health care, and social determinants of health which may adversely affect their outcomes. In 2019, our emergency department took care of over 100,000 patients. As we see in our daily work, hospital readmissions may use ED and inpatient resources unnecessarily. For some patients, staying out of the hospital may be safer. The 30-day readmission timeframe is commonly used to look at healthcare resource utilization, and in some cases, it may be tied to hospital reimbursement for services. Our objective was to determine whether or not a hospitalist-led team could be used to reduce readmissions within 30 days of an initial admission. The team consisted of hospitalists, ED providers, and case management/social work. We began our study in June 2018 and included all Medicare patients age 65 or older who presented to our ED within 30 days of a hospital admission. The process is presented here. As you can see, patients who presented within the 30 days of an initial admission triggered an email alert to a designated hospitalist and case management team as part of our SWAT team. The patient's most recent admission was reviewed in depth, and any phone calls that were necessary to get collateral information were made. At that point, a call was made to the current ED provider to discuss the case in detail, and shared decision-making was used to decide if the patient required readmission. There was also discussion of services that may be available in the outpatient world that may prevent a readmission. As you can see, usage of this SWAT team led to a statistically significant decrease in readmissions within 30 days of initial discharge for the patient population studied. 438 patients were looked at before the process began, and 439 patients after the process began. In the 6 months before implementation of this process, 72.4% of eligible patients were readmitted to the hospital on their return visit to the ED. For the 6 months after the implementation of the process, 66.7% of eligible patients were readmitted to the hospital on their return visit to the ED. We conclude that a multidisciplinary approach is necessary to prevent unnecessary readmissions and thus reduce the use of hospital resources. Collaboration between hospitalists and ED providers may be an approach to accomplish this. In the future, it would be interesting to look at ways in which the type of a collaborative team can be used to reduce admissions for specific subpopulations of patients, for example, orthopedic patients or patients with heart failure. Thank you for your time, and I'd be happy to answer any questions.